Hello everyone. Today I'm going to go through the 11 steps to analyse an ECG. First, a few basic principles you should apply to anything that you assess. As soon as you're asked to comment on the result of any investigation, you should always first check the name to ensure that it is the correct patient. Also, check the date to ensure you're looking at the correct result of the patient. Then, more specific to ECGs, check the calibration of the ECG, which will be printed on the tracing. This is the calibration which the ECG machine uses when printing the tracing. Normally, it is set at 25 mm per second, so that each big square represents 0.2 seconds. Each big square is made up of 5 smaller squares, and so each of these smaller squares represents 0.04 seconds. This is important to know when using the ECG to calculate the heart rate. So, I use 11 steps when assessing an ECG. Analysing ECGs using a methodical stepwise approach ensures that nothing is missed. As this slide shows, I start by assessing the rhythm, followed by the rate, axes, the P wave, PR interval, QRS complex, Q wave, R wave, S wave, ST segment change, and finally I look at the T wave. So, first thing to check is the rhythm of the ECG to see if the heart rate is sinus, regular or irregular. A P wave before every QRS complex makes it a sinus rhythm. For it to be regular, the intervals between the QRS complex should be constant. For this, I usually check the interval between R waves. If this is difficult to do with the eye, use a piece of paper and mark on the edge of it the position of 3 consecutive R waves. Then move the paper down the ECG tracing. If the ECG is regular, the points marked on the paper should still align with the R waves. Now check the rate of the ECG. The normal heart rate should be between 60 and 100 beats per minute. To check this, on an ECG that is regular, measure the number of big squares between 2 consecutive R waves and then divide this number into 300 to give the rate. So, for example, if the R to R interval were 4 big squares, divide 300 by 4 to give 75. The heart rate of the ECG would therefore be 75 beats per minute. Then check to see if there is any axis deviation. Normal axis is between -30 degrees and 90 degrees. Use leads 1, 2 and 3 to check the axes of the ECG. Positive QRS complexes in leads 1 and 2 indicate a normal axis. There can be different causes of axis deviation, for example a pulmonary embolism for right axis deviation or Wolff-Parkinson-White syndrome for both left and right axis deviation. In left axis deviation, there will be positive QRS complexes in lead 1 and negative QRS complexes in lead 3. For right axis deviation, there are negative QRS complexes in lead 1 and positive QRS complexes in lead 3. A simple way to remember this is in left axis deviation, it looks as though the complexes are leaving from the middle, and so is left axis deviation. In right axis deviation, the complexes look like they are returning. Then check the P wave. It should be less than 2.5 mm in height and less than 3 small squares in width, so 0.12 seconds. If a P wave is taller than what it should be, this is an indication of right atrial enlargement. If the P wave looks bifid, almost like an M, this is an indication of left atrial enlargement. The PR interval starts at the beginning of the P wave and ends at the R wave. It should be between 3 to 5 small squares. The P wave represents depolarization of the atria. This electrical activity then travels through the atrioventricular node to the ventricles to cause ventricular depolarization, represented by the QRS complexes seen on the ECG. And so, a widened PR interval represents a delay in conduction between the atria and ventricles. A short PR interval might, on the other hand, mean that there is conduction by an alternative pathway to the atrioventricular node, an aberrant pathway. Then I look at the QRS complex, which should be less than 3 small squares in width. A widened, broad QRS complex is pathological. Having looked at the QRS complex as a whole, now we start to look at the individual components of the complex, starting with the Q wave. The Q wave is the negative deflection preceding the R wave. The normal Q wave is less than 1 small square wide and 2 small squares deep. Large Q waves are pathological, indicating either a past myocardial infarction or even a myocardial infarction within the last 6 hours. Step 8 involves the R wave. The R wave is the only positive deflection of the complex. On a normal ECG, you may notice what is called an R wave progression, whereby going from V1 to V5, the R wave actually gets larger, starting off smallest in V1. In step 8, we look at the R wave in leads V1, V2 and V3, where the R wave should be relatively small still. If, however, the R wave is equal to or larger than its subsequent S wave, this is pathological. An R wave larger than what it should be in leads V1 to V3 indicates either right ventricular hypertrophy or a posterior infarction. Again, for the S wave, start off by looking at V1 to V3. If the deepest S wave of the 3 leads is larger than 4 big squares, then add this number of squares to the larger R wave of either V5 or V6. If this number after addition of the squares exceeds 7, then there is left ventricular hypertrophy. After finishing with the Q, R and S, we'll look at the ST segment. An important point here is that if in step 6 the QRS complex is wider than what it should be, we do not need to do steps 10 or 11. Assuming the prior steps all show a normal ECG, we now look to see if the segment between the S and T wave is at all elevated or depressed from the baseline. Finally, if there is no ST segment changes, we move on to look at the T wave. The T wave should normally be in the same direction as the QRS complex. So, if the T wave is negative and so is the corresponding QRS complex, this is normal. Inversion of the T wave, otherwise, in the presence of a positive QRS complex, can be a sign of ischemia or past infarction. Tall, tented T waves, a sign of hyperkalemia or the hyperacute stage of a myocardial infarction. So, in summary, first assess to see if the ECG is regular or irregular. Step 2. Check the rate of the ECG. Step 3. Check if there is left or right axis deviation. Step 4. Check the P wave for normal size and shape. Step 5. Check the PR interval for any problem with conduction between the atria and ventricles. Step 6. Check the width of the QRS complex is not enlarged. Step 7, 8 and 9. Check the deflections of the Q, R and S individually, looking for any signs of past infarction or ventricular hypertrophy. Step 10. Check the ST segment for any depression or elevation from the baseline. Step 11. Finish by looking for an abnormal T wave. The best thing to do now is practice. It is difficult to immediately apply these steps, so try and use them in as many ECGs as you can get your hands on. I will be uploading more tutorials of what to do and what it means when you encounter abnormalities on the ECG. I hope this was useful. Thanks.